I'd like to introduce Joanna Rock to invite our speaker this morning.
All right. All right, thank you. Good morning. I'm very honored for this opportunity to introduce our Women in Medicine Grand Round speaker, who is the current Executive Vice President and the Chief Executive Officer of the American College of Physicians, Dr. Daryl Moyer. She began her career at University of Pennsylvania, where she received her Bachelor's of Arts in the biological basis of behavior, biology, and psychology. She then went to medical school and internal medicine residency at the Temple University Hospital in Philadelphia, where she was chief resident. After there, she went to infectious disease fellowship at Harbor UCLA Medical Center. She's had a remarkable career thus far and has held many positions and received multiple awards. As a board certified internist and infectious disease specialist, she has served on the ACP's Board of Regents, governors, and as the governor of the Southeast Pennsylvania ACP chapter. She was also a professor of medicine, executive vice chair for education in the Department of Medicine, the internal medicine program director, and assistant dean for graduate medical education with the Lewis Katz School of Medicine at Temple University. And she still practices clinically part-time with Temple University Internal Medicine Associates. She has received a multitude of awards, including most recently the American Medical Women Association's Elizabeth Blackwell Award and the Lewis Katz School of Medicine at Temple University Alumni Achievement Award in 2020. She holds many scholarly interests, including those in medical education, high-value care, patient safety, professionalism, and digital media, gender equity, and HIV and infectious disease. She is a wonderful role model and a dynamic speaker, and I'm just thrilled that she agreed to join us today. So with that, I will let her take over the meeting and get started.
Thank you, Dr. Rock and Dr. Sharma, and thank you, Mr. Sodani and your family for this incredible honor and for all that you've done for patient care and the healthcare professionals. It's really my pleasure to be here today. We can dive right in. Let me see if I can screen share. I am warning you ahead of time that the cable people have been stalking my neighborhood for the last day, and I got kicked off of meetings 6 times yesterday. So I'm praying that doesn't happen today. So good morning. It really is a pleasure to be here. I want to thank you for the invitation. A little bit about me. I cannot be what I cannot see. Time to unleash a JEDI healthcare environment. If I could ask everyone to mute themselves, that would be great. So when you hear the word JEDI, you probably think of this. This is our implicit bias hitting us. Rather than thinking of this as JEDI. So for some disclosures, I am a full-time employee of the ACP. I'm an adjunct professor, and I still see patients on a part-time basis at the Temple Internal Medicine Associates. Many thanks to my physician colleagues and society organizational staff for a lot of the content that we all share together that's used in this presentation. I want to give a big shout out to Dr. Susan Thompson Hingle, who was really the visionary leader that worked with a group of us to really kickstart the ACP's journey in this arena, as well as our women leaders that have been in leadership at ACP, including Ana Maria Lopez, Jacqueline Fincher, and Heather Ganser. So we're going to go over some of the data that are germane to women, but there's really a lot of intersectionality here, and they're germane to everyone who is underrepresented in medicine. We're going to review obstacles, but most importantly, we're going to talk about some actionable interventions to work towards achieving equity at the micro and macro levels for everyone. And like a mini mental status exam, remember the following phrases: the pink elephant, the ladies' bathroom, the crowded intersection, the energized village, doing the right thing, and the iceberg. So the pink elephant in the room is that when we have a more diverse and inclusive group of folks sitting at our leadership tables, driving decision-making and leadership at our institutions, we all get more. It's not a zero-sum game. All the data whether it's healthcare business or non-healthcare business, demonstrates that the more inclusive and diverse group of decision makers you have, the better outcomes you have for your organization. And we also know that environments that are free of harassment and discrimination deliver higher quality care and are much safer for patients. And that's a space we all want to be in. In terms of the gender equity specifically, there's data around improvement in productivity, creativity, communication, employment, job satisfaction, work engagement, and policy development at your organization. So it's really a win-win for all when we have a more equitable environment. Now, for women, this is frequently how it feels. We're doing everything we can to make him comfortable, short of dressing up as male doctors. And I know all the women in the, that are on this Zoom can relate to this because of the implicit bias and the microaggressions and the explicit bias that sometimes we suffer in the patient care setting. And sometimes it's the patients and the patient's visitors. It's not other healthcare professionals that are inflicting the microaggressions, the bias, the harassment and discrimination. There has been a lot written around compensation for women and other underrepresented groups in healthcare. And this is a follow-up on Losasso's 2011 study from Health Affairs. This was published in 2020. And essentially what they found that was when they adjusted for every possible variable in this survey that was conducted amongst New York physicians, female physicians came up short. And the explanations for the gender gap remain, quote, elusive, according to this title. This is ACP's compensation survey that we published in the Annals of Internal Medicine in November of 2018. And we again tried to control for every possible factor. And basically what we found was that there was a significant salary gap between men and women of around $50,000 or more, regardless of whether the women that responded in this survey were partnered or not partnered, married or not married. And the AAMC data from a couple of years ago found the same thing in terms of the gender gap for compensation at every possible level in an academic health center. And so we are seeing that there has been some movement of women for progress in the academic leadership pathway. But we really need to shift the tectonic plate here because we still see that if we take a look at department chairs or deans at medical schools, less than 20% of the time, these are women, despite the fact that now over half of the matriculants at US medical schools are women, and soon half the graduate medical trainees in the United States will be women. It is particularly problematic for women of color and men of color. This is Dr. Julie Silver's work around Her Time Is Now, a campaign that was launched last September. And she called it the inexorable zero, that Black women and other women of color, Hispanic women, accounted for less than 1% of full professors at academic health centers in the United States. And if you actually take a look at the data around Black men and medical school, there has been no increase. It's been completely flat in terms of the admission of Black men to medical school since the late 1970s. Dr. Quinn Capers thinks that in some circumstances, even if women have been shown to outperform men in terms of following evidence-based guidelines, there's no rational explanation for why so many brilliant women are underpaid and underpromoted in academia. And I would urge you at your own institution to not just track the numbers, but track the turnover. When you take a look at why people are leaving your institution, who's leaving and why are they leaving, and track that data as well. That gives a much fuller picture. Now, there's a really strong signal on the quality of care of women and underrepresented in medicine physicians. They're more likely to follow EBM guidelines in several studies that we've seen. Women physicians are more likely to provide patient-centered communication and health counseling compared to male physicians. That's why they spend more time in the room. And that is one of the hypotheses for the decreased compensation, that they're not making the same productivity benchmarks because we just haven't appropriately adjusted them for the different expectations that patients have between their female practitioners and their male practitioners. Both male and female patients expect more time in the room with their female practitioners. They expect them to be more comprehensive. And it's also known that female practitioners are much more likely to deal with socio-behavioral issues and deal with routine GYN care on women in the primary care setting. Patients with female practitioners in some studies were more likely to receive guideline recommended treatment for heart failure and diabetes, and they may have had better clinical outcomes. Compared with majority group physicians, underrepresented physicians are more likely to care for underserved Medicaid and poor patients. It's the same trend we've seen with women physicians. And URM patients are more likely to consent to both preventative and health services if the recommending physician has congruity with them from a racial perspective. So this really makes us say, how do we get our healthcare practitioners to look like the patients that we are taking care of? So the gendered expectations, particularly for female physicians, really takes a toll. Because female physicians are more likely to have female patients and more patients with medical complexity that take up more time. There's in some studies, and in this study that was published by Mark Linzer in JEDI from 2018, a 60% excess in burnout in female versus male physicians because of those differing expectations in empathy, listening time, decisiveness. And this also has implications for patient evaluations. Some very forward-thinking institutions have totally upended the patient satisfaction metrics that they have implemented, and they have actually taken an equity lens to them. So how do we possibly have any solutions here? Maybe we should start adjusting for patient gender and compensation plans. Education, co-locating behavioral medicine specialists, particularly in settings where we know that our practitioners are dealing with socio-behavioral issues out of proportion, and adjusting visit times. Because we know that a more professionally satisfied workforce impacts patient adherence, it improves patient adherence, it impacts medical errors, it impacts physician retention, and we all know the toll, both human and financial, that physician and other practitioner turnover has for organizations. And it also improves patient satisfaction. Now, actually, this is Dr. Caper's study that was published in the journal. Oh, can I ask everyone to please mute? Thank you. The Journal of the American Heart Association last August. And this was basically a survey of all cardiovascular training programs across the United States that was conducted by the ACC. And basically, there are some fabulous references in this article that talk about that are the key references of the benefits of underrepresented physicians in the patient setting. And there are some key references on the benefits of female physicians. And I did send this slide deck in, so you'll have all of these references for you. So in order to know where we need to go, we need to know where we are. And in this large survey, which 110 out of the 193 programs, cardiovascular training programs in the US were represented, 84% of these fellowship program directors said underrepresented in medicine were also underrepresented in their institution. And in 2015, 6% of cardiology fellows self-identified as underrepresented, and this was about 11% in 2018. And this was a 12-question survey. These programs, about 70% said they believed that diversity was a driver of excellence in the healthcare setting. About a third said they were uncertain or did not believe the statement. About 2/3 chose our program is diverse already, so diversity does not need to be increased, despite those numbers that I just showed you. Over 1/3 wanted to increase diversity, but only 6% of the programs listed diversity as a top 3 priority when creating fellowship rank lists, and less than half of those program directors had a plan to increase diversity. The top 3 factors in ranking cardiovascular fellowship program applicants were clinical skills and acumen, ability to fit in and be a team player, and I noticed that quote, fit in, what does that mean? And research productivity were the top 3 priorities of the cardiovascular training programs. And here they are, and you see down at the bottom, diversity and ability to enhance diversity was only a top factor, one of the top 3 factors for 6% of the programs. So how do we get to a better place? And this was a study that was published by Dr. Pam Douglas and Dr. Reimer out of the Duke Cardiovascular Fellowship a little bit earlier this year in JAMA Network Open. This was a multi-pronged, comprehensive initiative that ran for 5 years from 2015 to 2019. And it started with a cardiovascular fellowship diversity and inclusivity task force. They drafted a bunch of comprehensive recommendations, including totally reorganizing their fellowship recruiting committee, changes to the applicant screening process, the interview day, the ranking process, and post-match interventions. And after these interventions, they saw a 25% increase in applications from both women and underrepresented in medicine groups. The interviewed applicants went from 20 to about over 1/3 for women fellowship applicants, and from 14% to underrepresented racial and ethnic groups. The matriculated fellows in this 5-year mean went from 27%, so about 1/4, to a little bit over 1/2 women, and from 6% to 1/3 underrepresented racial and ethnic groups. And overall, because of the intersectionality of these characteristics, if women or underrepresented racial and ethnic groups went from about 1/4 to 2/3 of their fellows during this 5-year period. And there were no significant changes nationally in terms of the characteristics of the fellow applicants. So we can learn a lot from that study, and I would urge that you pull that study and look at it. This was a study that was published that talked about the percent of women that were involved in those famous acronym cardiology trials published in New England Journal, Journal of the AMA, or Lancet. And really, it was in somewhere between the 40 and 60%, where there were no female investigators or no female physicians on the leadership committees of those major trials that were published. So how do we build bridges over troubled waters to our underrepresented groups? And this is an article from Campbell and JAMA Network last year, and talked about the problem with the Flexner report. And essentially what this talks about is that even though Blacks comprise 13% of the US population, only 5% of physicians are Black. And only several historically Black college and university medical schools remained open after the Flexner report. And this was an extrapolation of the data from the schools that remained open. And if those schools had not been closed at the time of the Flexner report, there would have been a 29% increase in Black physicians by the year 2019. And to add to this data, we should also point out that 0 of the 30 new medical schools that have been opened since the year 2000 and associated with the AAMC were located at historically Black colleges or universities, and none have been specifically focused on health disparities. I will note that the Cherokee Nation and the Oklahoma State University established the OSU School of Osteopathic Medicine at Cherokee Nation within the last year. And so this is really quite a tragedy. And this is despite the fact that we know that physicians from historically Black medical schools disproportionately pursue clinical practice research and advocacy that target the needs of medically underserved communities. So we all need to work together as a village to review all the opportunities, starting in preschool, access to socioeconomic support, resources, reduction of debt burden, addressing coaching, mentorship, and sponsorship opportunities. So those pathways are open for underrepresented kids who want to aspire to careers in medicine. So Dr. Eliza Low-Chin, the CEO of the American Medical Women's Association, says the partnership of institutions, medical societies, and academic journals will be a pivotal step in ensuring systemic change that addresses gender equity within the full context of diversity, equity, and inclusion. So I'm going to talk a little bit about medical societies, and here is a picture from the 1982 ACP Board of Governors, and you can see it is very homogeneous, it is very male, it is very white male. So we're making some progress, as other medical societies are, and we're all on different points on our journey. This is a study from Dr. Silver that was published in the Journal of the AMA Internal Medicine. Some societies have had quite a few women who have been presidents of their society in this 10-year scoping study from 2007 to 2017, and some are at 0%. And if you take a look at professional societies, boards of trustees, regents, directors, whoever their big board is, ACP, we have a lot of congruency in terms of women that represent, that are on our big board, and being basically equivalent to the number of women in our society, but it's not the same for every board. So this is Dr. Reshma Jagsi's study from Academic Medicine last year, and she basically took a look between 2000 and 2015 and saw that 10 societies have increased the mean percentage of women serving on governing boards by approximately 10% over the study period. And you can see ACP was there, as well as some of our medical subspecialty societies, as well as our dermatology friends, and our neurosurgery friends, our pediatric friends, radiation oncology and radiology. Now, we should also really take a look at how things are named at our institutions and our organizations. And if you take a look at recognition awards, this study, which takes a look at the American Academy of Physical Medicine and Rehabilitation, shows that in the blue bars, it's reversed. So the blue bars are women, the red bars are men. And you can see that in their recognition awards at that society, they had a large number of men compared to women who were winning their recognition awards. And really, we also need to make sure that our recognition awards are really reflecting our evolving goals and objectives and our organization and keeping up. And so I would really urge you to take a look at your own recognition awards and say, who are we missing here? Don't we have more international medical graduates? Don't we have more women? Don't we have more early career folks that are really demonstrating excellence at our organization? So where are the women? This is a picture. I don't know if you recognize this picture. This is a picture of the Freedom Caucus that met on the Hill in 2017. The irony of this picture, that is all men, is that the subject of discussion was women's health. Well, I'm going to tell you in a very tongue-in-cheek way, and all the women on this call can relate to this. Where are the women? We're all standing in line at the restroom. And, you know, the long lines at ladies' restrooms are really a metaphor for the structural issues that confront all of our institutions and organizations. Because these women didn't build these organizations, these stadiums, these concert venues. because they were built by architects who didn't appreciate that women have different biological issues when they need to use the bathroom, can't use the bathroom as quickly as men can. We don't blame the women for having to stand in these lines, and we certainly don't expect them to fix this structural issue, nor should we do that at our institutions. We can have grassroots at our institutions, that's really important, but what we need are the people at the top to empower, to allow that those systemic and structural flaws that have allowed these inequities to flow need to be fixed. Because easy fixes like this, like slapping a temporary sign over the men's room and turning it into a ladies' restroom, as is what happened at a major AMWA convention in Brooklyn in 2018, are not going to fix the issue. So shattering this glass ceiling is an urgent priority. We cannot expect women to do this by themselves. We can't expect our underrepresented groups to do it by themselves. This is why we need to be a village. We need to be all in, and we need to ensure that the folks in power are engaged and are helping us to get to the right place. So healthcare and medicine is an evidence-driven place, and we need to have the metrics around this. So I would urge you to take a look at this paper by Dr. Silver, Be Ethical. She leads healthcare.com. It's a systemic process, and we need to have metrics. We need to absolutely look at our data through both a gender and full-on equity lens around an organization's mission, vision, goals, and our ethical codes of conduct. We should report the results transparently to all stakeholders. We need to investigate the cause of disparities and implement strategies to address them. We need to track our outcomes and adjust our strategies as needed. And we need to report and publish our results. And in this report, I'm just going to show you a few highlighted sections here. She actually subcategorizes them into various different groups. And for metrics for all leaders, who's on your board? And on your board, are you making sure you have a diverse and inclusive board of directors that represents the patients that you're caring for? And are you making sure to include the traditionally underrepresented groups that are sitting on those boards on impactful committees and initiatives? Thank you for introducing me by my professional title. Because it's well known that women and underrepresented folks don't get introduced by their professional titles as much as white men do. So in terms of other metrics for all leaders, who's doing the financial allocation? Who has financial control? Who has financial priority? You might be establishing task forces and committees, but unless you give them the teeth that they need and the resources that they need, you're not going to have any impact. How are assistants allocated, administrative, clinical, and research? We know that total compensation just isn't about the money, but it's about the support that we give folks in the clinical, research, and administrative realm. What about the training opportunities that you're affording various folks at your institution? Who's getting asked to participate? Who are directors? Who are the faculty? Who are the speakers that you're inviting in? How do you handle formal complaints of harassment or mistreatment? And are you conducting workplace culture surveys? And not only are you conducting them, but are you fixing the problems that you will find on those surveys? Because it is a really crowded intersection. There is a lot of intersectionality here around equity, and it takes a village. And this is sadly the last picture that we took with an executive committee for the American College of Physicians. This was taken in one of our conference rooms in January of 2020 with our executive committee, and we were very proud that Better is Possible, a new vision for American healthcare, was published in Annals in January of 2020, where we talk about various things that the college ACP believes we need to get to a better place for healthcare, and health equity was a big focus actually of that. So the college is really energized and is trying to do the right thing. And we're trying to help everyone else along by talking about our journey. And I want to talk about, this is where, you know, our young people in our organization were really leading the way and continue to lead the way. And I hope that you'll look to your younger folks in your organization to do the same. So in September of 2016, a resolution was brought to the ACP Board of Governors. It happened to coincide with my first month on the job as CEO at ACP. And it was a resolution for the college to develop broad and comprehensive policy around gender equity in physician compensation and career advancement. And it culminated in this paper, which was published in Annals of Internal Medicine in April of 2018. However, policy papers and position papers and your own organizational policies will sit on shelves and grow dust if you don't implement them, and you need to be able to implement them. And we were able to energize and mobilize around that. And what we talked about in this paper was physician compensation, family and medical leave, leadership development, unconscious bias, implicit bias training, research on inequity, and the full-on opposition to harassment, discrimination, and retaliation. And it has resulted in two really important websites that I hope you'll Google and go to after this talk. One is the ACP Women in Medicine website, and the other is our DEI and Inclusion website. And there is a lot of overlap in these websites because of the intersectionality issues that I talked about. So we've been doing a lot here. We established a standing committee. We now have a full-on policy committee that reports to the Board of Regents and is chaired by a member of our governance. We took an equity lens to the college's vision, mission, goals, and we revised them. We updated our policies. We established an anti-harassment policy and a seamless report, an anonymous reporting process. And we also put into place an approach and policy around professional behavior at ACP events and when folks were representing ACP in external collaborations. We've surveyed our past and current leaders. We're establishing a lot of created programming with our chapters because we understand that important pathway to leadership at national and international ACP is from our grassroots and our chapters. And we've created a lot of shovel-ready programming for them. In fact, I've personally done at least a dozen talks with various groups in our chapters around equity in the past 6 months alone. We've also done a lot around policy and advocacy, not just for the healthcare and for physicians that are ACP members, but for our patients. We're forging external collaborations. We've developed pilots for affinity groups. We've revised our national and mastership descriptions to remove biased language and potential barriers to nominations. We're tracking and reviewing our data, making adjustments, publishing it. We're communicating, coordinating, and collaborating with others in the space. And I'm going to give you an example here of a big change that we've seen. And we took really a lens to our mastership and awards. And we saw that from 2007 to 2014, less than 10 women a year were nominated for MACP. And in 2007, 2008, 4 out of 80 MACP nominees were women, and all were selected. Every single one of those 4 women were selected, but only 9% of the overall group was selected. And what we did was we did a seismic shift in this by peeking around corners and really doing deliberate practice to look for folks that were being overlooked, so that by 2019, 2020, 27 of the 87 MACP nominees and 2/3 of them were actually selected to become MACPs versus 1/3 of the male group. And the overall group was 1/3 women, 2/3 men, which reflects the practicing physician percentages we have in our organization. And in 2020, 2021, again, a third of our MACPs are women, 22% of our awardees are women, which has been some progress, but we are also looking to see, are our awards reflective of our evolving goals and objectives and values for our organization? And in terms of our journal, which is Annals of Internal Medicine, Dr. Christine Lane is our editor-in-chief, and we have incredible gender equity at our journal as well, in terms of our deputy editors, our associate editors, our editorial board, our publication committee. Now, you can talk about getting to a just, equitable, diverse, inclusive, or JEDI environment, but you also need to ensure that you have made a commitment to be actively anti-racist at your organization, and the college did this last fall. So equity in the time of COVID, I think it has not been lost on us that we have seen incredible inequities in both our patients groups and our healthcare professional groups in the time of COVID. And we certainly see the intersecting US epidemics of COVID-19 and lack of health insurance and the impact it had, particularly early on in the epidemic. And this time must be different. We've got to address these disparities for once and for all in our patients, and for once and for all with our healthcare practitioners. And this is really a COVID conundrum. This has really been, unfortunately, a perfect storm and a perfect prescription for inequities, with disproportionate impact on marginalized populations, essential workers, and healthcare professionals. I want to point out that 3/4 of the healthcare practitioners who have been infected with COVID have been women. We know that women physicians disproportionately work in communities hit hardest by COVID, as are underrepresented ethnic and racial group physicians. There is a perpetual second shift, or also known as the third shift, for female healthcare professional caregivers. And really, there's been tremendous burnout in everyone in the healthcare community, but it's been particularly bad for women and for those that really have had those double burdens of caregiving while trying to continue to do their job. And I'd refer you to Dr. Jane's article, The Third Shift, in the Journal of Women's Health, that was published in 2020, that talked about promotions and career advancement in COVID. And we also saw that there was rapid pivot, and this happened at your organization, in the med ed realm, to suddenly switch everything to virtual. And many of medical educators are disproportionately women at academic institutions. We also saw lots of things happen in terms of first author and senior author publications going down significantly. Orange bars 2019, blue bars 2020, in the first couple of quarters of that COVID hit last year. This was a Nature article that also demonstrated the same thing in terms of the rapid diminution in authorships by women. We've also seen fewer projects, grant projects filed at clinicaltrials.gov and some of the other organizations. And this is the orange bars were March and April of 2020 versus earlier that year in the gray bars, or actually in 2019. And we know that fewer projects, research projects, are going to lead to fewer publications for women in the long run. And then, of course, there's the inescapable pressure of being a woman on Zoom. So can we sort of fill these gaps with COVID activities? And this is Dr. Vinnie Arora on a Women in Medicine Summit webinar, where she talked about promotion and tenure clock stops and shifts, giving credit for clinical educational service, media advocacy work, social media work, and research around COVID, providing bridge funding, facilitating group work dynamics, and really putting the full spotlight. And she put together a rubric that she presented at the Women in Medicine webinar in 2020 that you can Google. that can help your promotion committees in terms of this. And this is actually Dr. Amy Gottlieb's article that was published in JEDI last fall, where she looked at 4 domains around academic productivity and gave some subdomains there that you can actually start to capture COVID-19 contributions. You can allow canceled scholarly activities to be listed on the CV, and you can develop promotional structures that full on recognize COVID-19 teaching, clinical care leadership, and administration, and extension of promotion deadlines. The second domain that Dr. Gottlieb and her co-authors talked about were in the compensation and professional effort arena, where she talks about ways that you can transparently look and share this data, and you can ensure that your DEI groups are engaged in decisions about this. And so these are really some really granular ways that you can really start to address this. The third domain that they looked at was around career development and how you can maintain institutional funding streams for programming that supports women's and other underrepresented folks' careers and their leadership development, and that you can ensure that women and other underrepresented folks have strong representation on promotion and search committees. And the fourth thing you need to be looking about is family support. How can you do flex work schedules? How can you partner with local businesses to offer to subsidize various aspects of things that we know need additional support? Women in the healthcare profession are not going away. And we need to work together as a community and think about how it could have been different. In terms of the number of child caregivers that went out of business during COVID. What if we had successfully partnered with those groups and made it a win-win for our organization as well as those organizations? So how can we fix this? But even if we afford flexibility in careers, if we build it, will they come? And unfortunately, because of the culture that we work in, the concerns about burdening colleagues and perceptions that people aren't as committed if we take leave, worry about career damage and FaceTime bias and limiting our future opportunities. This study by Dr. Howell that was published in Academic Medicine in 2017 looked at the University of California system, which has had a flexible policy around family and childbearing leaves and stopping the clock since 1988, but only 7% of women and 0% of men have actually used those policies. Maybe we should make them opt out rather than opt in. So what we know is that women and underrepresented groups in medicine are recruited, evaluated, advanced, promoted, mentored, sponsored, and compensated differently than those in the majority power holding groups. And this holds for UME, GME, practicing physicians, and in patient satisfaction data. There's data around women conference introductions, their speaking time, the amount of times they're interrupted, the appropriation of their comments and contributions. And despite the fact that the National Academy requirements that AAMC affiliated hospitals and healthcare organizations maintain a clearly written Bill of Rights and responsibilities that should communicate a zero tolerance policy for sexual harassment against healthcare practitioners, when in this study that Viglianti published in JAMA Network Open last September, 0 out of 55 policies that were pulled at AAMC institutions around the country recommended specific language against patient-perpetuated sexual harassment or abuse. And sadly, we see emerging data around increasing prevalence of personal attacks and sexual harassment of physicians on social media, with women reporting significantly more online sexual harassment than men. So this was a study that was conducted at the Duke, the UCSF and the UCLA internal medicine residency programs that was published last year. And this was internal medicine resident physician experiences and biased patients. And in the graph on the left side, the black bars are Latino, Latinx, whatever your preferred terminology is, and Black. The green bar were Asian residents, and the white bar is white residents. And you can see in every domain of belittling or demeaning stereotypes, role questioning, explicit epithets or outright rejection of care, and sexual harassment was much more suffered by folks that were either underrepresented or in the group on the right by women more than men. And, you know, the prevalence was really, really disturbing of what we were seeing. And the frequency of the responses by these internal medicine residents really range from really doing nothing, maybe setting one-on-one limits, sometimes doing debriefings with others, but rarely was it creating a team response plan, reporting to the attending physician, reporting to the institution. And not addressing the incident at all was frequently a path that was taken by the internal medicine residents. And why? Why did they just put up with it and tolerate it? And if you take a look at the factors that were impeding the residents from responding to biased patient behavior, it was because they cared about the patients and they prioritized the clinical care. They felt unsupported by the team, their senior physicians, their institution, and frequently they didn't have the knowledge or the skills about how to properly respond. And they were just feeling overwhelmed. So maybe what we should be doing is, in addition to doing rapid response training with our teams and huddling proactively with our teams around clinical issues, we should also be instilling the skill sets in our individual healthcare practitioners and our teams to be able to respond to biased behavior by patients, visitors, and by other members of the healthcare professional team. You know, as I went around, and I've done a lot of these grand rounds, I remember I went to Montefiore and they told us that they actually did this. They proactively trained their teams to respond, so that if a doctor was in the room with a nurse and a patient or a visitor or another healthcare professional was unprofessional with that nurse, there was an immediate timeout, and the other healthcare professional in the room said, "Excuse me, patient X," or "Excuse me, whoever." This is a professional environment at our organization, and giving you the highest quality, safest care is important. But you need to treat our healthcare professionals professionally, and that type of behavior, that type of language is not tolerated at our organization. So I would urge that you have these conversations and you coach folks to be able to respond in the moment in a safe and professional way, because frequently these comments and these actions happen and we're just left with our mouths agape and we don't know how to respond. So we really need to educate each other and have each other's backs, because what lies beneath these sorts of issues is really a big iceberg of microaggressions, micro-infractions, micro-misappropriations that are happening every day. And it's really the tip of the iceberg is when things rise to the level where folks get reported into the academic sexual misconduct database. And this was a study that was reported a couple of years ago. The authors abstracted the characteristics of the alleged perpetrators in this database. So this is really when things get to the level that they get reported on this database. And this was, they basically identified 125 faculty sexual misconducts that were reported into this database. And again, this is just the tip of the iceberg. 98% of the perpetuators were male, about 3/4 of them targeted subordinates, half of them were full professors, 30% committed sexual assault, 56% sexual harassment, only half of them resigned or retired, 21% were terminated. But 50 of these 125 accused faculty remained in academia, 60% at the same institution that they were reported on this database, and 40% at a different institution. And we really need to be able to address this in a way to make sure that we stop these practices in their tracks. So what is the role? The role of AAMC, ACGME Joint Commission. So all of these organizations have very strict language around non-tolerance of harassment and discrimination in the workplace. There's also a role of state licensing and health boards, of healthcare institutional rating systems, and other credentialers. And if you take a look at the ACGME, they have common program requirements around language, around inclusivity, diversity, around lactation facilities and accommodations for healthcare practitioners with disabilities. And Dr. Lisa Bellini wrote in the Journal of Women's Health with her group a project where they were able to identify appropriate, safe, accessible lactation facilities for all the women that worked at the University of Pennsylvania campus. And this was published in 2018. I urge that you look at this. So the ACGME Common Program Requirements also has strong language around non-tolerance of sexual harassment, discrimination in the healthcare environment, as well as the clinical learning environment review professionalism requirements for the ACGME. The Joint Commission has strong language around diverse and inclusive, equitable healthcare workplaces and how that translates to a safer, higher quality institution. And this is a study that from several cases right out of the Joint Commission that I published last year in conjunction with Dr. Esther Chu and Dr. Anna McKee, who is the CMO of the Joint Commission, that talked about how sexual harassment was undermining safety and quality cultures at an institution. And the Joint Commission has a hotline for this as well. So allyship is no longer an option. I'm going to end and say, we've got to make sure that this is an imperative, and men and folks that are in the positions of power have to support equality. And we can do this together. We can perform that foundational work. We can do that hard work of reviewing our policies and procedures and the governance rules of our organization. We can make sure we have anti-harassment and discrimination policies, and most importantly, make sure we have accessible mechanisms for activation of these policies that are not going to ostracize or marginalize the folks that activate them. We've got to establish bodies that have teeth for ensuring a JEDI and anti-racist goals at our organization. We've got to take a look at how we prioritize resources. We've got to collect the data. We've got to track all of the data at our organization. We've got to publish it. We've got to educate everyone with the elevator story, like I hope I did today, to talk about how more diverse, inclusive, equitable environments that are free of harassment and discrimination are safer, higher quality organizations. And we've got to make sure we're adhering to all of those credentialing, licensing, and accrediting requirements, because she is someone's sister, mother, daughter, wife. So the next time you think about JEDI, I hope you don't think about this picture, but I hope you think about a picture such as this. And this is a picture of a couple of our former leaders dancing the night away and also dancing ACP really into a more equitable place. And as Amanda Gorman said, there is always light if only we're brave enough to see it, if only we're brave enough to be it. So with that, I am going to thank you for your attention and stop my quick screen share and see what questions we might have from the group.
Thank you, Dr. Moyer. That was great. And the resources you gave are fantastic. The one with ACP in particular was crucial in starting our own Women in Medicine group. So thank you for that. We did have one question. So a major issue that needs to be addressed is the provision of childcare facilities that are conveniently located for use by trainees and faculty. This would be at a considerable cost to the system, but may go a long way to alleviate stresses on women in these roles. So what is your opinion on this?
Absolutely. I mean, this is, I think, a big issue. And I think it's not just childcare facilities, but it's flexibility in our policies. And so I think that it's really important that you look to your community partners here. You know, the University of Pennsylvania has been very, very successful in working with their community partners to ensure that med students, trainees, nurses, physicians, pharmacists, CRNAs, techs, transportation folks have good childcare that because of these community partnerships. So I think you absolutely need to look to these Better Business Bureau and take a look and see what you have in your own backyard and see what you can figure out, because you know, one of the major issues for why so many healthcare organizations don't want to go into the childcare business, which is sort of, I think, really short-sighted, because take a look at who's taking care of your patients and look at what happened in COVID. And it builds a compelling case for working with your currently bonded and insured childcare providers in your community. To see how you can provide those flexible ability for childcare. And, you know, the other request that people are getting is we're seeing more adult dependent care that's needed because of this crisis of caregiving we have in our country. So I would say it's time for you to sit down with your local businesses, your local financial people, and your childcare providers in your community, and maybe your WISE, et cetera, and come up with a global plan to fix this for once and for all.
Dr. Moyer, thank you so much. I'm Dr. Catherine Monteleone. I have been at the school a long time, and every problem you mentioned, we have. And we're a unionized faculty. I'm proud to be the president of that union. We tried during the negotiations to bring up the AAMC white paper and to get a compensation committee. Our school would not allow it. We have local compensation committees started from the faculty, but none maybe that have teeth because the school won't buy into it. We tried to get a paternity leave policy. We got 10 days for only the people who have been here only 1 year or 2 years, I'm sorry. I told them that 25 years ago, I had 3 months paid leave. Unbelievably, the answer of a senior physician, now administrator, was that's why UMD&J went bankrupt.
Well, you know, again,
you know, I mean, that's how do you, so my questions are two. How do you get the school to buy in? And how do you get the faculty to buy in? Because when we ask women to back us, to sign petitions, very hard because of fear of retaliation, fear of speaking up. How do you do that? How do you move these two groups? Because otherwise we have no teeth.
So what happened at ACP is that we had people on the board, and we knew who allies were on the board that were going to champion this, because this is why you need to talk directly to your board, and you need to give them the elevator story about everything I talked about and the tsunami of data around better outcomes at your organization at every possible data point when you do this and do this right. So you need to find out who your friends are on the board and get their ear. That is very clear, that once the board and members of the board feel empowered and understand the elevator story here, things start to move. You need to go to those leaders and you need to tell everyone in your organization why this is critical. And you need to start to, again, get very, very granular around your governance rules, around your policies and procedures, and around your data collection. I think you're going to start to see that AAMC is going to, start to move in that direction more. You also need to point out exactly what I just talked to you about in terms of the AAMC LCME requirements, the ACGME requirements, the Joint Commission requirements. There's no better way to hold people's feet to the fire than for them to understand what the regulations are in order to have that licensed, accredited sponsoring institutions for UME, GME, and Joint Commission for Patient Care, because that's exactly what the story is. So I think you need to push down the gas and pull on all those levers, but you have to get the ear of the governing board for the institution.
If I can ask a question, Darilyn, thank you for that presentation. What I see a lot of discussion in the clinical environment around communication, calling that timeout when it's appropriate. I think the best way to do it is to do it live at the right moment. And we should encourage trainees and others, and I see this a lot amongst our healthcare professional team, of turning to mechanisms like Verge or Midas, which are reporting systems, and putting that information there. While that might be helpful to have a track record, it never solves the problem in real time. So I think open communication, like you alluded to, is critical.
No, absolutely. And I think that, we've got to practice this. And when I used to do inpatient medicine, this was something I learned over time, because things had happened to me where I just didn't know how to respond. And I knew that things that were happening to other folks as well. And so I felt it was really important to proactively and preemptively be able to have our team be aware of this. So I do think it's really critical that we model this behavior. We do it in real time as appropriate. But at the same time, that doesn't mitigate the responsibility to do the formal reporting as required. I always used to think of Midas as a, kind of a big black box sort of thing. But I think that it's really good that, if you can present sort of what's going into Midas and how we're addressing, issues that we're seeing around X, Y, and Z. But you're absolutely right, Dr. Sharma, you have to be able to know where, when, how to respond, and how to do it in a professional way and a safe way for your teams. And we have to, just like we model good clinical behavior for our teams, we have to model this type of behavior and show and teach it, just like we do clinical issues.
Thank you, Dr. Moyer. And I believe Dr. Cohen had a question for you.
Oh, yeah. Thank you, Dr. Moyer. And it was a great talk. It's great to hear not just you pointing out all the issues, but also some takeaways for actions that we can use to improve how we recruit, and also how we care for our underrepresented minority students and trainees and colleagues. I guess my question is, when we know that one of these individuals, a student, a trainee, or a colleague, is a female or is a person of color, these actions are easier than if this is somebody from an underrepresented minority that we don't know. Mm-hmm. For example, if this is somebody with different sexual orientation, transgender, somebody who has a disability that we may not know about, or even something that we face when we are going through applications for residency and fellowships, and the individual may not declare that they are somebody from a race or an ethnic minority. How do we use some of these actions for these individuals?
I think that's a great question. And I don't have an answer for that, quite frankly. I think we need to start to push out the message that we celebrate diversity of every type. And I think once we sort of build that culture and that transparency and that openness to recognize that we need all hands on deck here. And I think people will start to potentially be more open about that when we are more open and we really mean it and we back it up with data where we can prove that we mean it. So I do think it is, I think it's a tricky issue. It's an evolving area. There are evolving areas and data and literature around this. But once again, I think we have to build it. We need to live it in an authentic way. And we need to be open and to welcome everyone to the party at your organization. I wish I had a magic bullet pixie dust answer for you.
Great, and we're running a little over, so maybe just one more question here. So this is from Dr. Jobanputra. There's also a lack of maternity leave. When women do take maternity leave, the clinical service time is still required and a decreased number of mother, not prorated service time. This takes away from researching, publishing, and essentially delayed promotions. Do you have any thoughts on this?
Well, I have a lot of thoughts on how we treat women physicians versus women nurses. We know 80% of the nursing are women, although actually a lot of leadership in nursing is disproportionately men when compared to the rank and file around nursing. Why don't we have pools that we develop for coverage, etc., for physicians, the way that we do for nurses? I think we need to sort of rethink about how we do work as physicians in our organization, because I know that you all are the same that I was. I drag myself in half dead sometimes to work, even though sometimes I was sicker than the patients I was taking care of, because I didn't want to unnecessarily burden my colleagues. I took way too short of a maternity leave after my first child than I should have. And I didn't repeat that the next time around. But how can we creatively work together to build up that additional staffing and coverage that we need so that people can take the amount of time that they really need? Because we know that, if we are supportive, if we're in a supportive culture, when people come back, they are really committed and dedicated and highly productive when they're professionally satisfied. So I believe that you pay it forward by figuring out systems like that.
All right, thank you, Dr. Moyer. Just one more question. I know I said the last one was the last one, but can you please repeat the elevator story for everyone?
So the elevator story is that it's not a zero-sum game, that when we have a more diverse and inclusive and engaged environment, we all get more, because every bit of literature, whether healthcare or non-healthcare businesses, is that organizations' performances improve when you have that diverse and inclusive environment. This is particularly germane in healthcare because in addition to the diversity and the inclusion and the engagement of folks that are at our organizations, we know that organizations that have cultures that are free of harassment and discrimination also lead to better outcomes for patients, higher quality and safer patient care. And we know that the organizations that accredit, credential, and license your organization want that also, and they have specific regulations around that.
Great, thank you so much.
Thank you so much, Daryl and Dr. Moyer. We really appreciate you giving of your precious time to be here. And for the rest of us on the call and for your friends, please join us tonight as our Women in Medicine group launches a symposium from 7 to 8:30 p.m. Thank you, everyone. Have a great day.
Thank you. Take care, everyone. Stay safe. Do what you can.
Thank you.
Thank you.
Bye.
Bye.